Guillain-Barre Syndrome, everything you need to know. Hey everyone, and welcome back to the channel. Today, we're diving deep into a complex neurological condition called Guillain-Barre Syndrome, often abbreviated as GBS. This video will be an educational resource for students, so buckle up and get ready to learn. Guillain-Barre Syndrome is a heterogeneous group of immune-mediated conditions. Guillain-Barre Syndrome is the most common acute, severe fulminant polyradiculopathy polyneuropathy. Usually demyelinating or rarely axonal. Often post-infectious, post-vaccinal basis monophasic does not recur. Etiology. Antecedent causes. Majority of patients have preceding acute, influenza-like illness or GL infection. Infections preceding GBS may be due to Campylobacter jejuni, cytomegalovirus, EBV, herpes virus, CMV and Mycoplasma pneumoniae, or prior recent vaccination, e.g., swine flu, influenza. Rabies. Frequently develop in patients with lymphoma, HIV seropositive, and SLE. Immunopathogenesis. Guillain-Barre syndrome is an acute-onset immune-mediated demyelinating neuropathy. Autoimmune basis for AIDP and other subtypes. Both cellular and humoral immune mechanism causes damage. Immune response self-antigen, infection, or vaccine-induced antibody responses. Molecular mimicry, i.e., sharing of homologous epitopes between microorganism liposaccharides and nerve gangliosides, misdirect the antibodies against host peripheral nerves. Antiganglioside antibodies mostly to GM1 common in GBS and anti-GQ1b Ig antibodies seen in Miller-Fisher syndrome. Clinical features. Hallmark is an acute, rapid onset of paralysis evolving over days, weeks with loss of deep tendon reflexes, jerk. Motor paralysis predominant. Weakness beginning in the distal limbs that rapidly ascends affecting proximal muscle function. It is more marked in legs than arms and proximally than distally. Pain in the low back, neck, and shoulder, in 50% and is often occur early. The weakness progresses proximally upward few days to a maximum of 4 weeks. Sensory involvement is minimal and may precede muscle weakness. It presents as distal paresthesia or loss of pain sensation. Facial and respiratory muscle weakness develops in 20 to 30% of cases requiring ventilatory support. No liver or constitutional symptoms at the onset of weakness. Bladder dysfunction in late severe cases. Clinical worsening in 4 weeks reaching a plateau and no further progression. Autonomic disturbances common like fluctuation of BP, postural hypotension, cardiac dysrhythmias. Physical examination shows diffuse weakness with loss of reflexes. Pain common symptom acute deep aching pain in weak muscles. It is self-limited. Miller-Fisher syndrome, it presents with ophthalmoplegia, ataxia and areflexia. Often preceded by diarrhea due to Campylobacter jejuni infection. Bickerstaff's brainstem encephalitis characterized by alteration in consciousness, paradoxical areflexia, ataxia, and ophthalmoparesis. Asbury and Kornblath criteria for Guillain-Barre syndrome. Required features. Progressive weakness in both arms and legs. Areflexia. Features supportive of diagnosis. Progression of symptoms over days to 4 weeks. Relative symmetry. Mild sensory signs or symptoms. Cranial nerve involvement, especially bilateral facial weakness. Recovery beginning 2 to 4 weeks after progression ceases. Autonomic dysfunction. Absence of fever at onset. Typical CSF. EMG, nerve conduction studies characteristic signs of a demyelinating process in the peripheral nerves. Features casting doubt on the diagnosis. Asymmetrical weakness. Persistent bladder and bowel dysfunction. Bladder or bowel dysfunction at onset. Greater than 50 mononuclear leukocytes per millimeter or presence of polymorphonuclear leukocytes in CSF. Distinct sensory level. Features that rule out the diagnosis. Hexacarbon abuse. Abnormal porphyrin metabolism. Recent diphtheria infection. Lead intoxication. Other similar conditions: poliomyelitis, botulism. Investigations, diagnosis. CSF findings: develop after 1 week of illness, raised protein, normal sugar, little or no pleocytosis. Cell count generally less than 10 cells per millimeter, rarely maybe up to 50 cells per millimeter, but never above that. This is called as albuminocytological dissociation. CSF pleocytosis is common in patients who have GBS and concurrent HIV infection. Electrodiagnostic study, nerve conduction studies, is mild, early stage, normal. In demyelination, prolonged distal latencies, slow conduction. Velocity, conduction block, prolonged F-wave latencies. Absent H reflex. In primary axonal, reduced amplitude of compound action potential without slow conduction. Antibodies. Antibodies against GQ1B, a ganglioside component of nerve, are found in about 25%, usually the motor axonal form. Miller-Fisher syndrome, antibodies against GQIB have 90% sensitivity. Differential diagnosis. For poliomyelitis, botulism, diphtheria, localized spinal cord syndromes or myasthenia gravis, vasculitis, toxins, organophosphates, diphtheria, porphyria, spinal cord or cauda equina syndrome. Treatment. Early treatment, each day counts, greater than 2 weeks of first motor symptoms, immunotherapy not effective. Initiative with high-dose IVIG plasmapheresis combination. Intravenous immunoglobulin administration has fewer side effects for 5 days. GBS autoantibodies are neutralized by antibody and IVIG. Patient should be screened for IgA deficiency because severe allergic reaction due to IgA antibodies may develop in patient with congenital IgA deficiency. Plasma exchange, 50 ml per kilogram, on 5 separate occasions over 1 to 2 weeks. Glucocorticoid no role. Worsening case, monitoring in intensive care unit, blood pressure, cardiac, and nutrition. Maintenance of airway and breathing ventilatory support may be needed. 20-30-40 rule, total capacity less than 20 ml per kilogram, negative inspiratory pressure less than -30 cm H2O, maximum expiratory pressure less than 40 cm HO is an indication for intubation. Full recovery in 55 to 69% by 1 year. Supportive measures: deep vein thrombosis prophylaxis, tracheostomy, chest physiotherapy. Thanks for joining me today. I hope this video helped you learn more about Guillain-Barre syndrome. If you have any questions, please leave them in the comments below. Don't forget to like and subscribe for more educational medical content.